Spencer King is next with Dr. Michael Criqui, Chief of the Division of Preventive Medicine at the University of California in San Diego, to discuss the ankle brachial index.
Michael, welcome to ACCEL.
Thank you.
Now, you're here talking about ankle brachial index used in two settings, one screening for vascular disease in people with unknown disease, and the other diagnosing obstructive disease, as it might be etiology for claudication or whatnot. Tell me, first of all, in regards to ankle brachial index for diagnostic or for screening to identify cardiovascular disease, how often is this applied in physician offices?
The uptake has been relatively modest. It's not applied that often. When we've done surveys and asked physicians why they don't use it, some physicians do use it very effectively. When we've asked physicians why they don't do it, the usual responses are, well, I don't know how to do it. Looks like it might be a little bit complicated, or I don't have time to do it, or it's not reimbursed.
We hear a lot of talk about it. It's kind of like the weather. People talk about ankle brachial index, and then the question is, do they do anything about it? Okay, you put a cuff, you can measure, you can feel the pulse, or you can listen with a Doppler or something, and you get some impression of this. But to do it right, give me a very short elevator speech about how this should be done.
Well, it is very important to use good technique in using the ankle brachial index. Conceptually, it's simple, and the equipment's simple. But like anything else, you can mess it up if you don't do it carefully. So the ankle brachial index, by definition, is the ratio of the blood pressure at the ankle divided by the blood pressure in the arm. So to do it correctly, you have to measure the blood pressure in both arms, not just one, which is the standard practice in the office. And the reason is we take the higher of the two pressures as the denominator for both the right ankle brachial index and the left ankle brachial index. Why do we use the higher of the two? Because in patients particularly that have peripheral arterial disease, that's the same group of people that have a relatively high prevalence of subclavian stenosis. So if you just take one arm pressure and you get the one where there's a blockage of the subclavian, you're getting a faulty low pressure, and that's going to distort your ankle brachial index. So you take both arms and you take the higher of the two. Then at the ankle, in each leg, we recommend measuring both the posterior tibial and the dorsalis pedis pulse. The reason for that is the dorsalis pedis is sometimes congenitally absent. You don't want to get fooled. The posterior tibial is sometimes completely blocked, though the anterior tibial is fine. And so in the case of leg pain, typically you'll have to have both arteries with atherosclerosis to get ischemia to the calf muscle. So for the right leg, you take the higher of the dorsalis pedis and posterior tibial artery and divide it by the higher of the arm pressures. And for the left ankle, you take the higher of the dorsalis pedis and posterior tibial artery and divide it by the higher of the two arm pressures. Now you have two ABIs, one on the right side and one on the left side. The index ABI for the patient is the lower of those two ABIs.
People wanting to do it who are not doing it now are going to have to read up on it and have to figure out how to do it. But if you do this, how reliable is it? Say this is a screening for patients at risk, patients with Framingham risk scores, but you don't have anything else to go on about coronary disease. Seeing the patient in the office, you do it well. How reliable is it, or how predictive of cardiovascular disease is it?
It's very predictive. The most important thing that people want to know nowadays is how predictive it is above and beyond the Framingham risk score. If I know somebody's risk factors, does this give me additional information? And the answer is yes. We published that in the Journal of the American Medical Association in July of 2007. We did an international collaboration of 16 studies and showed in those 16 studies that it was highly predictive for very hard endpoints such as total mortality, as well as cardiovascular mortality and all cardiovascular disease. And the prediction value was substantially beyond the Framingham risk score, such that you could correctly reclassify people to higher or lower risk once you knew the ankle brachial index.
So there are a host of things that can reclassify people, like CRP and carotid endomal medial thickening, coronary calcification. Where does ankle brachial index fit in your mind in terms of value in reclassifying people as far as their cardiovascular risk?
For that specific purpose of reclassifying people, it fits really well in people where there is a substantial prevalence of abnormal ABIs, and that is the population 60 and above, or patients who are smokers who have diabetes. If you measure it in younger people, it's basically a dichotomous variable. It's either above 0.9 or below 0.9. So you don't find it much in younger people unless they're very, very high risk. So it works well in the older population or with people with substantial risk factors. I think the test characteristics in terms of reclassification are pretty good. The only one I think that consistently is better is coronary artery calcium in terms of classifying risk.
If we're looking at coronary disease, that's measuring coronaries, and this is measuring something else, so it's more direct, yeah.
You're talking specifically about overall cardiovascular risk. And for whatever reason, an abnormal ABI is just as predictive of a future coronary event as previously having a coronary event, or having angina. I mean, it is equally predictive with angina, surprisingly. It simply represents the generalized nature of atherosclerosis.
All right, well, let's shift gears just a little bit and talk about how it's used in terms of diagnosing people with peripheral vascular disease who may benefit from therapy.
Well, it's just a huge improvement on the standard office practice. When I went to medical school, maybe when you did as well, we were taught to ask people about claudication. And the test characteristics of claudication, there are a lot of false positives and a lot of false negatives. We were asked to feel their pulses. And I think that works pretty well if you got a bounding pulse. But, when your pulses get a little bit thready, then the intern and the attending and the senior guy, they all disagree about whether the pulse is there or not. And so what we found with them is they're not terribly good either. And so really, if you want a non-invasive way to measure whether or not PAD is present, the ABI beats pulses, it beats asking about leg pain, it beats hair growth and color and all those things hands down. It's got excellent test characteristics, and it takes 5 to 10 minutes, honestly about 10 minutes in office practice. If someone has exercise calf pain, for example, or exercise leg pain, and they have an abnormal ABI, the chances that they're having symptomatic PAD is extremely high.
Well, most of our listeners are cardiologists, I believe, and many of them call themselves cardiovascular specialists, and the board exam actually says that. So I think it is very interesting and important for them to pay attention to the vascular system beyond the heart, and this certainly is an important ingredient of that, to diagnose peripheral vascular disease, because it's part of our responsibility to care for those patients and also to reclassify patients in their overall cardiovascular risk. Listen, we appreciate you visiting with us here on ACCEL. Thank you so much, and we look forward to more contributions from you. Thank you.
Thank you.